afternoon. I want to thank everyone who's been able to log in today and join us for this webinar entitled Recognizing and Responding to Teen Dating Violence in the Clinical Setting. Before we dive into today's topic, I want to address just a few housekeeping items for folks. If you are having any technical difficulties, please reread your confirmation emails that you received this morning. The latest one was sent around 10 a.m. Eastern Time. And in those emails, you'll find links to join the meeting as well as call-in information if you're having any audio issues. You should be able to hear the audio through your computer speakers. If you're not hearing any sound, we recommend the tried and true approach of logging off and logging back into the session. And if you have any further technical issues, please feel free to send us a message in the question and answer box, which you should see on the right-hand side of your screen. If you have any questions for our presenters as we go along today, please also use the question and answer box to send them our way. Please note that all participants in the session will be able to view those questions that you ask or the comments that are submitted. And we have planned time at the end of our presentation today for questions and answers. So we'll do our best to get to as many of those as we're able to. Unfortunately, because of the large group we have joining us today, we won't be able to open up the lines for audio or verbal questions. So we'll use the Q&A box. And lastly, this webinar is being recorded and will be posted on our website, violence.chop.edu, within the next week. If you are a social worker or nurse joining us today, there is an opportunity to receive continuing education credits for this webinar. Again, additional information was provided in the reminder email you received from Eventbrite this morning. If you wish to obtain these credits, please note that you must be logged in as an individual, so by your own name, not in a group, for the full duration of the webinar to be eligible to claim CEU credits. If you need to, you will also need to complete the online evaluation form when we end the webinar today. Amanda Lerman, Christine Forke Young, Teresa Salinas, and I, Rachel Myers, have the ability to control or influence the content of this educational activity, and we have each completed and signed a conflict disclosure of relevant financial relationships form, affirming that neither us nor our spouse's partners have or have had in the past 12 months any relevant relationships with commercial interests that could be perceived as a conflict of interest for this educational activity. If you have any questions or experience any difficulties in obtaining your continuing education credits, please send an email to Madeline Smith, whose contact information is here as well. Today's webinar is being hosted by the Center for Violence Prevention at the Children's Hospital of Philadelphia. We have close to over 200 people who registered and are joining us for today's webinar, which I think really speaks to the interest and concern in addressing the issues of teen dating violence within our community. Among the participants, we have folks from very diverse disciplines, including medicine, social work, social services, education, and research. And so I am Rachel Myers, and I'm here as the moderator today. I serve as the research director for the Violence Intervention Program and a research scholar in the Children's Hospital of Philadelphia Center for Violence Prevention, where I work very closely with our Stop IPV program. And now it's my pleasure and privilege to introduce our speakers for today. Amanda Lerman is an attending physician in the Division of Adolescent Medicine at CHOP. Dr. Christine Forke Young is an associate in the CHOP Center for Violence Prevention. And Teresa Salinas is an intimate partner violence specialist at Children's Hospital of Philadelphia Center for Violence Prevention and a medical advocate at Lutheran Settlement House, a community partner. Our specific learning objectives today are to explain the issue of teen dating violence, how it differs from bullying and adult intimate partner violence, and the long-standing impact on individuals, to understand how to recognize teen dating violence, how it can be addressed in a healthcare setting, and where to find information or resources to support youth who may be experiencing violence. And then lastly, to identify action steps that you can take to become a teen dating violence prevention champion in your own setting to help protect patients or caregivers who may be experiencing violence. And so as we get started today, we'd like to open with a quick poll question for our audience members, just to get a better sense of who's joining us. So our first question should pop up in a second for folks. And first, we just want to get a better sense of the settings in which you work. So for folks who are joining us, which best describes the setting in which you work with teens? And get to the results. It looks like we have a very large clinical audience today, which is great because really what we're focusing on is how to implement some practices to support and identify violence, or support teens who may be experiencing violence and identify them in your clinical work. As well as a good number of folks are coming to us from community-based settings or educational settings. Our second question, just to get people warmed up before we talk at you for a little while today, we can switch to the next poll, which is, how prepared do you feel to address teen dating violence among the patients or the teens with whom you work? Looks like answers are coming in. It looks like some folks are finding they fall somewhere in the middle. Somewhat is always the most popular answer, and that's true for our lunchtime crowd today. So hopefully through this talk today, we'll again give you some background information and then really help give you some tools, tips, and techniques that you can integrate into your own practice and settings. All right, that's all the work you had to do for now, so thanks for participating. As we get started today, I also do want to acknowledge that violence in intimate relationships is an unfortunately common experience that affects many members of our communities. And we recognize that for those joining us today, or for our families, our friends, our coworkers, or other acquaintances, intimate partner violence may be a familiar experience. And so our goal today is to provide information that can help you provide care and support to the teens and young adults with whom you work. But please know that we will be providing resources at the end of this session today that can be helpful to many, regardless of age and experience. And so as we begin, I wanted to acknowledge that when we talk about teen dating violence, we're really talking about violence that can occur across a wide developmental range. Dating and violence can and do occur in early adolescence or tween relationships, and continue through older adolescence and early adulthood or emerging adulthood. In fact, 1 in 5 teens report that their first romantic or dating relationships occurred before the age of 13. So if we really want to think about addressing dating violence among teens, we must do so early in adolescence as opposed to waiting until later adolescence. Importantly, intimate partner violence is common and commonly occurs in early adolescence. Data from the Centers for Disease Control and Prevention has found that 1 in 4 women who experience IPV first reported the violence occurred before they were 18, with over 70% reporting violence first occurred before they were 24, so sometime during this adolescent period that we're talking about. And over half of male victims reported the violence first occurred before they were 24. In our own work locally, we found that 45% of college students who experienced IPV first experienced such violence during the ages of 13 to 17. So violence is happening early in adolescent dating relationships. In adult-focused work, we typically hear of the terms intimate partner or domestic violence, and they're commonly used somewhat interchangeably in the field. When we talk about teen or adolescent dating violence, there are a lot of similar terms that are used to describe the pattern of behaviors involving violence within intimate relationships. So you may hear dating violence or dating abuse, relationship violence. All of these terms are used somewhat interchangeably, which can lead to some language and terminology barriers. But know that when you hear these terms, they are commonly being used to describe the same set of health behaviors. And so what are those health behaviors? Dating abuse is a pattern of coercive, intimidating, or manipulative behaviors used to exert power and control over a partner. And while we define dating violence as a pattern, that doesn't mean that the first instance of abuse isn't also dating violence. We simply recognize that dating violence tends to involve a series of behaviors repeated over a course of time. And among individuals, but particularly adolescents or teens, it's important to note that such violence can occur between current and former partners, so even after you've left a partnership. It affects individuals of all gender identities and within both heterosexual and same-sex partnerships. So there may be a popular image of teen dating violence that presents as a female victim or survivor of a male offender. Teen dating violence really can occur regardless of gender, race, socioeconomic status, education, or sexual identity. Violence can also occur in a single relationship, but may also continue across multiple relationships over time, making universal education and routine inquiry of utmost importance for our teens. And so what's in a name? One of the unique challenges of assessing and responding to teen dating violence starts in the vocabulary of dating and violence. And we assume that many of you joining us today would consider yourself adults. I'm not going to put a boundary on what adult means. But I think the definition of dating that teens use, and particularly young teens use, can be quite different than what a care provider might conceptualize or ask. And so some definitions to help sort of ground us in what we're talking about with dating violence could be the CDC uses a definition of someone you were dating or going out with. Other research efforts with input from teens themselves have defined dating as things like seeing someone, talking with someone, hooking up. And so it's important that when we're thinking about talking with teens and young adults, thinking about talking with their families, to think about a more expansive definition of dating. Because we may say, are you dating someone? And the teen may say, I'm not dating anyone, I'm talking with someone. Similarly, defining violence can also be a challenge. We'll talk in a moment about some of the types of intimate partner violence that affect teens. But in general, it's best to use really behaviorally based questions to help teens recognize the violence that may be happening in their relationships. But important to recognize that a teen's concept of violent, unhealthy, or unwanted relationship behaviors may defy those usual definitions or boundaries we put around relationship violence. And so they often have described things like disrespect in their relationships, relationship drama, or behaviors that cross a line or a boundary, which is a bit different than how we might define it typically. And so while physical and sexual violence tend to be spoken of and depicted most frequently, dating violence can occur in a variety of ways as shown here. Particularly among teens and adolescents, emotional or verbal abuse, so behaviors such as insults, monitoring or isolation from peers or friends and family can be particularly of concern, as well as digital abuse or violence that's perpetrated through digital means such as bullying, behaviors, stalking behaviors, intimidation are important considerations. For teens, we also worry about reproductive coercion, which is related to sexual abuse, but can include pregnancy pressures, birth control sabotage, refusing to use birth control in an attempt to control a partner's pregnancy. It's important to acknowledge as well that violence is not omnipresent in most relationships. Rather, it may follow a repeated pattern or phases, namely periods of tension building, characterized by mounting frustration or anger, nitpicking, arguing behaviors. An individual experiencing violence may try to calm the offender or appease them in some way, and the victim survivor may be on guard or careful to manage their emotions to avoid creating additional tension in the relationship. After a period of escalating tension, violence may erupt, and this can include the forms of violence previously described, ranging from physical to emotional, digital to sexual. This is typically followed by a honeymoon period where offenders may try to woo their partner, offering gifts, excessive kindness, promises that violence will never happen again in a relationship may be common. Some relationships may also then be characterized by a relatively stable or calm phase where behaviors appear healthy and predictable. There could be efforts to rationalize or explain prior episodes of violence, again with promises that it'll never happen again. However, because dating violence is a pattern of behaviors, this cycle commonly repeats over time before an unhealthy or violent relationship may end. And so it's important in working with teens to know that relationship patterns and behaviors can be cyclical. And so while violence may not be a concern today or during a single clinical visit or single conversation with an adolescent, that doesn't mean it's never happening within a relationship. And so I think having this framework in mind of going through this cycle, being in these phases is important when we think about discussing healthy and unhealthy relationship behaviors. And so we've described what we're talking about here today and some of the different forms or types of dating violence that teens may commonly experience. I want to pause briefly and acknowledge some of the factors that may differentiate teen dating violence from more commonly assessed and discussed IPV among adults. So namely, one of our important considerations are the stages of development in adolescence. And so it's a period, we know it's a period of rapid transition and development, accompanied by changes in cognition, maturity, decision-making. And the nature of intimate relationships also changes dramatically during this period, particularly as teens begin to increase their independence from caregivers and draw closer to their partners and peers. In terms of peer influences, there is a strong influence of social network and peer behaviors on teens. Teens may be particularly hesitant to acknowledge or disclose violence that they're experiencing in a relationship out of concern for jeopardizing close or shared friendships with their partners if they're parts of the same peer group. In terms of cyber abuse, which Teresa will share a bit more about in a moment, digitally perpetrated abuse is exceedingly common among teens. Although many report they don't necessarily view this as violence or dating abuse, but an annoying behavior perpetrated by their partner. And so I think it's important to consider that violence can occur both in a cycle, but also along a continuum of what is healthy or unhealthy for an individual. In research among adolescents, violent behaviors or coercive tactics may often be reported by both partners in a relationship. And while this may not be mutual violence, typically one partner is still exerting control or power over the other, it's important to note that adolescents may engage in a range of unhealthy behaviors within their relationships. In terms of cohabitation, many teens are not yet residing with their violent partner, and so this potentially offers unique approaches to safety planning, particularly in partnership with supportive adults in a youth's life. However, youth may still spend lots of time with their partners, such as in school or places of employment, and this can make establishing safety more challenging, particularly as these environments can offer a limited supervision. We'll talk a bit more in this session around safety planning and protection from abuse orders, but do note that the ability of teens under 18 to obtain protection from abuse orders varies from state to state. And while this may be an intervention with variable success in helping victims, survivors establish safety, it may be a tool that's less accessible to our teen populations. And then lastly, in terms of confidentiality and reporting requirements, as others will share today, it's important to share the limits of confidentiality with those you're initiating conversations with that may be affected by violence. But this is especially true for teens, where state laws around mandated reporting may be different than when providing care to adult patients or those over 18. This is particularly true for younger adolescents and younger teens around setting boundaries of what you can keep in confidence and what you need to share, as well as around cases of sexual assault disclosures. And so now I'm going to turn it over to Teresa to share a bit more with you.
Thank you so much, Rachel, for laying the groundwork so comprehensively and clearly. Moving from the conversation, differentiating between teen and adult intimate partner violence experiences, we also really wanted to be sure to discuss teen dating violence versus bullying. And I believe that this comes up a lot, both in familial and community narratives and dialogues. And I think it's really important to inform our understanding of this issue and how we respond to it and approach it into the future. So basically what we're looking at is some information on this slide is from Rutgers School of Social Work. What we understand is that there is a correlation between incidents of teen dating violence and bullying behaviors, which might not surprise folks. Specifically, we know that middle school youth who engaged in high rates of self-reported bullying perpetration, meaning they are the bully, are 7 times more likely to self-report engaging in physical abuse towards a dating partner in high school, or what we're calling physical TDV. So that correlation is quite significant. However, these two experiences in terms of perpetration and victimization are not the same. So we'd like to differentiate that there are different goals and connections in the relationships in these two different instances of violence. Mainly that the teen dating violence partner's goal, as we've said previous, is to have power and control over their partner or the victim. There's an emotional connection there and an attachment. The goal or the function of the abuse is to keep that person in the relationship and to maintain that power and control dynamic. Conversely, a bully's goal or someone who is, perpetrating either emotional or physical harm towards a peer is to damage the victim and to harm the victim. But there isn't that same emotional connection or attachment that exists within a teen dating violence relationship. So I think a lot of times our systems address these things as the same issue when we know, in fact, that they're highly correlated, but they are different in terms of dynamics and goals. And on the next slide, I want to go over, I know this is a lot of text, but I think discussing some of the prevailing myths or maybe misconceptions around teen dating violence and offering a correction to those narratives or the facts behind them, right? So, the myths that basically teens are less likely to experience violence than adults is not true, It can happen in any dating relationship, and as Rachel has touched upon, this happens quite early in adolescence oftentimes. It's not only occurring in later adolescence or adulthood. It's also not only a problem experienced by girls and young women. We know that it can affect teens of any gender identity or sexual orientation. In fact, LGBTQ plus youth are often at higher risk for teen dating violence due to a number of factors. And it can happen in any dating relationship, no matter what language we're using for that relationship. And then, basically, there is such a focus on the inherent risk of damages that physical and sexual abuse and the impact that has on young people. However, most violence and, the pattern of abuse is very often incorporates emotional abuse or other patterns of abuse that, are not limited to just physical violence. And I'll talk a little bit more about co-occurring abuse in the next few slides. The fact that violence is perpetrated from one partner towards the other, completely one-directionally. We do know that in teen and adult dating relationships, survivors can and do engage in what are considered abusive behaviors in self-defense or as a way to try to get power and control back in the IPV or the TDV relationship. So, going forward, just knowing that this is not just an issue for girls, it affects all genders and relationships, and it's not just limited to physical and sexual violence. A very key and simple statistic is the prevalence of teen dating violence. 1 in 3, right? So It's very common, and this prevalence stat of 1 in 3 is based on a sample of high school students self-reporting or self-identifying that they are or have been in an abusive relationship. So again, that could mean many different things to those teens who have experienced that. What we do know is that, 1 in 3 have experienced it. About 1 in 5 have experienced physical abuse from a dating partner. And just a little under 10% reported sexual abuse or sexual violence from a dating partner. And the next slide, as promised, going to go over what, co-occurring abuses, what the trends are, and how we kind of frame it. So what we do know is that individuals may and often do experience multiple types of dating violence or partner abuse. And there is a connection between digital abuse and other forms of abuse. So we know that most adolescents who report digital abuse also report experiencing another form of abuse, right? So I think a lot of times we like to check ourselves on thinking, oh, well, it's just digital abuse, or no one's physically, hurting you, or, it's all behind a screen, or, oh, this person doesn't do emotionally abusive or manipulative things in front of other people or in person. But we know that, the likelihood of another type of abuse occurring when digital abuse is present in the relationship, that likelihood is fairly high. So digital abuse victims are twice as likely to be physically abused, 2.5 times more likely to be psychologically or mentally abused, and 5 times more likely to be sexually coerced, meaning that, certain sexual actions or practices, or even reproductive coercion, as Rachel previously mentioned, that likelihood increases quite significantly. And this may occur in one relationship or across relationships as well. In terms of the bidirectionality or the mutual violence in teen dating relationships, it's unclear whether the physical and psychological impact is the same for both partners in the relationship versus, someone who's choosing to be abusive towards their partner versus the partner who's being abused. But, these characteristics might differentiate that IPB during adolescence different from those observed in adult relationships. So what we know is most cyber dating abuse victims, or, people who have been affected by sexual coercion, mental abuse, or cyber abuse, did not report perpetrating that same type of abuse against another person. But a lot of individuals do report both being affected by this abuse and being the victim, as well as perpetrating abuse against another partner. And this happens in up to 50% of adolescent relationships where violence or abuse is happening. There are a lot of statistics out there. I really would encourage, folks to read a little bit more about those incidence rates, but just know that it's nuanced, and this is happening in kind of reverse order in a lot of different relationships. So someone who might have been abused in a dating relationship previously, that they ended that relationship or they left that relationship, they might be at higher risk for perpetrating violence against their partner in the future. And then the next slide, which, the title here is Outcomes of TDV. And obviously, every single person, adolescent or adult, is impacted differently by trauma, right? So I just want to acknowledge that. There are a lot of shared characteristics between the list on this slide, as well as the previous lists of risk factors that we've discussed, and also what we consider or observe as red flags, right? For when we're looking for warning signs that, a teen might be experiencing dating abuse. But, our understanding of this issue really is dependent on and relies on study design and methodology, basically how the research is structured, really informing our understanding of this. So it's complicating our understanding of the phenomenons, but understanding that if someone has been abused in a teen dating relationship, suicidality, unhealthy diet behaviors, some low self-esteem, worsening mental health symptoms, substance use, things like that, could be related to the abuse that they are experiencing or have survived. So with that, I just want to pass it off to our next section here, the healthcare visit.
Thank you, Teresa. So now we're going to turn the focus to the healthcare visit and what we as healthcare professionals, which so many of us in the audience are, can do to help teens experiencing dating violence or relationship abuse. So even though we know this problem, as Rachel and Teresa have just shared, is sadly very common, studies show we are missing most of the opportunities to ask about it. And that means that we're also missing chances to help. When asked if healthcare providers had ever asked them about TD views, in most studies, fewer than 30% of teens say that they have. And we know this is the case even though the major professional societies, regulatory organizations, and advisory boards, including the ones listed here, the American Academy of Pediatrics, the Joint Commission on Accreditation of Healthcare Organizations, JCAHO, and the USPSTF, the United States Preventative Services Task Force, all recommend screening for dating violence and relationship abuse in all patients over the age of 13 in a variety of healthcare settings, and regardless of chief complaint or the reason why they presented for care that day. As our understanding of this issue continues to develop, there's also a movement to grow from a universal screening to include also universal education. And what that means is we should screen, we should ask the right questions, and we'll talk in a moment about how to ask those. But even if our patient says no, we should still be offering universal guidance, resources, and continued discussion at future visits. So ideally, information about healthy relationships will come from trusted adults in multiple settings. And I know the audience today includes people who work in healthcare and in many other settings. So wherever we're providing universal education and screening, it is important to use a team approach. In healthcare, that means in our clinics, in our inpatient wards, and our ERs, some patients may feel more comfortable divulging to one team member over another. So it's not necessarily the doctor or necessarily the nurse who's in the best position to be having these conversations. And any member of the team can pick up a sign that a patient needs help. So all team members need to be prepared to respond with positive, healthy messages and with resources, and to do so in a non-judgmental way. It's crucial to ask the questions and provide help when patients disclose the need. But we also know that some patients with the need won't tell us, or they won't tell us the first time we ask. So it's also vital that in a universal way we provide resources with all our patients so that they can have the means to seek care when they're ready to do so. We also know that some young people may never disclose to a healthcare provider, and they may never disclose to any concerned, trusting adult, but they may disclose to a friend or another peer or a family member. So by providing messaging about healthy relationships and resources about where to get help when needed to the teens that we have in front of us, we can also equip them to help support other teens in need. So how do we approach this issue with teens? RADAR is an acronym created by the Massachusetts Medical Society in 1992 and adapted into a clinical tool that can guide us in addressing these issues in the clinical setting. So the first R in RADAR is for routine, meaning routine universal screening. And this reminds us to make addressing this issue routine and universal in all our encounters. Before we start, we need to set the stage. The private psychosocial portion of a healthcare visit with a minor always begins with honest, clear explanations about confidentiality. either using that term confidentiality or and explaining what it is, because it's a big word that not all teens or even adults may understand, or using plainer language about what information you can and can't keep private by law. Unfortunately, the laws requiring mandatory reporting of child abuse by a parent or caregiver are often much clearer than the laws that pertain to peer violence and abuse. And we know that those laws can vary pretty widely from state to state for adolescents when it comes to abuse by a partner. As a healthcare provider, therefore, it's really crucial to get to know the laws in our own states regarding minor consent and confidentiality, regarding abuse, including physical and sexual abuse, and statutory rape laws, so that we can clearly explain them to our patients. And remember that it's important to be transparent about the limits of confidentiality before asking questions, but also before starting to provide any education or anticipatory guidance, since just talking about this might trigger a spontaneous disclosure. So there's no perfect one way to say this, and in terms of setting the stage, I would say we all develop our own style over time, seeing patients, but to give some example language that might include, now I have some questions about your life in general. We ask all of our patients about a number of things in their personal lives so that we can better know what's going on with them and how we might be able to help them and how we can keep them safe and healthy. Everything you share with me today is your information, so I want you to know that by law, I can't share any of it with anyone outside the medical team without your permission. And that's true for everything we talk about, with a couple exceptions, so I need to tell you about those exceptions up front. And then the way you describe those is going to vary, and here it'll depend a lot on what the state laws are. But for example, what I like to say is, anything you tell me that makes me think your life is in danger is not something I can keep private, because I would need to get you help immediately. If you tell me that you are thinking of hurting or killing someone else, I can't keep that private. And if I find out that anyone is hurting you or abusing you, then I would need to get you help, so I wouldn't be able to keep that private. Also, as Rachel touched on earlier, teens may use different language than those of us who are older use, and it is important to mirror the language that the patient is using. So we're speaking the same language, so that we are understanding each other best, so that there are fewer barriers between us. And so a teen today might not say, this boy that I am dating. They might say, that guy I'm talking to. Then you want to say, so about that guy you're talking to. And be prepared for whatever they say. Try to stay neutral, try to stay concerned, try to avoid looking shocked, so that we are perceived as empathetic and not judging, and have those resources at the ready. And then keep asking. The best universal screening is ongoing. And that's because, as we mentioned before, teens may not be forthcoming right away, and maybe they'll disclose later after developing more trust. But it's also because they themselves may be in a process of evolving understanding or evolving recognition of what's going on. So they may think the answers are no and later realize that they're yes. So when do we screen? The short answer is whenever we can, anytime, always. Whenever an opportunity is there. Obviously, there are constraints in our healthcare visits, but it is best to have this in mind all the time and to have a way to incorporate it into most visits. Certain visits are a particularly high yield, and those are some of the ones that are on the slide. So it's particularly important to ask about relationship abuse and violence when patients are coming in for their routine well visits, when we're checking in with them in general about their lives. And for when they're coming in for reasons relating to teen dating and relating to sexual activity, like the reproductive health care visits that are listed here, seeking testing or treatment for sexually transmitted infections, seeking contraception or emergency contraception, or seeking pregnancy testing or treatment. When they're coming in with an acute complaint, it's also important to think about this. If an acute concern is something that could have been related to violence or abuse, like an injury, for example, that could have been the result of violence, and could be considered a red flag. So we'll get into red flags more in a moment. I'll also underscore again here that it's important to keep in mind the importance of the team approach and to make sure that each member of the staff that the team will meet. And that includes clinical staff. It also includes front desk staff, anybody that the team may meet and interact with is prepared to recognize the signs and red flags and respond to them. Since last year in particular, it is obvious to everybody here that a lot of these visits may be happening virtually, way more than happened prior to the pandemic. And I just want to note here that ensuring privacy during those types of visits that happen over a screen is particularly challenging. It's not impossible, but it can be harder to know when the patient environment is truly private. For more guidance, the Journal of Adolescent Health had a nice statement about this last July that you can look up. It's called Supporting Adolescents and Young Adults Exposed to or Experiencing Violence During the COVID-19 Pandemic. But I'll just summarize a few things that, in general, the literature has come up with that we can do to make these encounters in this type of screening as safe as possible. So first, if you're in an encounter where there is a family member or a different person present, to normalize early in the visit that there's always going to be a confidential portion of the visit when we will expect to talk to patients alone, so that you can plan up front with them for full physical and auditory privacy in a different room or in a different space by having them move and hear up front if there are going to be barriers to that. Also, even if you have the patient alone, to ask directly, even if they appear to be alone, who's around right now, and ask if whoever's there can hear and can see, and then you can try to creatively plan for privacy together. And also just be mindful that it might be hard for patients to answer fully honestly if they feel uncomfortable with someone else there. So just kind of have your antennae up. In particular for signs of the patient looking a little bit uncomfortable or having difficulty responding to those questions. And when in doubt, offer an in-person visit if you can. Moving on, I mentioned earlier that there are some red flags for teen dating violence and relationship abuse. There's a lot of stuff on this screen. And it's important to screen and educate whenever we can, but particularly if any of these things that are here is present. So these are the patients for whom we may want to do a bit of a deeper dive with some of our questions and some of our education rather than just what our basic standard is. And I'm not going to go through every single thing that's on these slides. I'm just going to acknowledge that some of these are more obvious, like if you have a patient there and there's a partner in the room who's unwilling to leave, or if you're treating someone who's had multiple STIs or multiple unwanted pregnancies. But there are also some things that are common chief complaints or clinical issues where it's also really crucial to think about possible influence of teen dating violence or relationship abuse. So, for example, for patients who are presenting with depression or with anxiety or with multiple somatic complaints without a physical cause identified. And it's also important to think about teen dating violence when certain other things might come up in a general private psychosocial history, like academic troubles, or like someone who is having a lot of difficulty with their family or doesn't have a family that's very supportive, that person's in particular at risk. Or someone who's had recent social upheaval, recent falling out with important friends, that can be a warning sign. Two very clear vulnerable times that I just want to point out where it's always important to ask are when patients are in new relationships or have recently gotten out of a relationship, a newly ended relationship. And again, even if our patient says no, these are situations in which we want to make sure to provide resources that they can access later, just in case. So a lot of common situations here, and that really underscores, as my colleagues were talking about before, the potential prevalence and really wide-reaching impact of this issue. On the flip side, there are some times we may want to hold off on addressing this topic. So this is just a reminder, there's often a lot going on in a healthcare visit. I find myself in a state of chaos a lot when I'm dealing with patients, but it is important just to focus and be mindful and aware that there are some times where you may want to hold off. So always making sure that we're in a space with the patient that is private and safe. And not screening in front of anyone else, essentially. Not screening when there are friends there, not screening if there are parents or other family members there, certainly not screening if there is a partner present. And this is also, it's also important to just be mindful of who's in the clinical space in general, especially if there is a partner waiting for them. So if you've heard that there is a partner out in the waiting room, this is going to vary how accessible the back spaces are where you're with patients from the waiting areas. In my clinic, luckily, there's a locked door, so not everywhere has that. And it's important to remember that there have been dangerous situations where a particularly motivated partner might find a way to sneak back or eavesdrop in front of a door. So know your space well. If necessary, let other team members help you with this. Help make sure your space for you and the patient is private and safe. We want to make sure in general that we are avoiding screening when making the patient talk about these things might actually end up putting them in greater danger. It is okay to discuss this with patients who may have children with them if the children are under 2 years old. Or if you have a patient who has a child who's older than 2 years old, there are ways to screen that are nonverbal and to provide resources that are nonverbal. So for example, one way to get around this sometimes when we want to screen with patients or with caregivers in our CHOP emergency department is that we have some laminated screening cards that the staff can hand to the patient and that just ask for a yes or a no, and that can clue us in for when a need is there to find a way to provide a referral or to follow up. Next slide. So as I mentioned earlier, when I was talking about virtual visits and telemedicine and telehealth, it is important to get privacy and safety. That goes for in-person visits as well. And so, as I also mentioned earlier, it's really key to set the stage early in the encounter, that there will be a part of the visit that involves talking with the patient alone. And be creative. I find this the easiest to do, I think, in the inpatient environment. We often are trying to do it when we're doing an initial admission and we, ask the patient or the patient's caregiver or whoever is with them, if they're not alone, to leave the room for a portion of the visit. But if that doesn't go over well or for some reason is a problem, with inpatients, it's easier because there's often, even if there are family members at bedside a lot, it's not often completely 24/7. So you can capitalize on a period of time where a parent goes to the cafeteria for 30 minutes and sees that opportunity. Sometimes I'll even sneak in and see the patient alone if there's one of my team members, like maybe one of the psychologists or someone else who's taken the parent out of the room to talk to them privately. In outpatient environments or in ERs or in other types of settings that aren't in healthcare, this can be a little more challenging. But there may be other ways that you can find, such as some of the ones listed on the board, or different ways that are specific to other settings to get the parent alone, to get the patient alone. And again, remembering to draw on the support of your team can often help. So now we're gonna take a moment and just I'd just like to ask you guys to put into the chat or the Q&A, what are some of the ways that you guys have been able to, in your settings, get the patient alone? You guys can ruminate on that for a moment. I'll just move on to the next slide. Maybe we can talk about it as we wrap up. So overall, what we're doing is we're providing a safe zone, and much of that is in relationship building. So with some patients, as I mentioned before, it may take multiple visits to establish trust and a comfort level and a readiness to talk. Remember to lead with transparency and a clear explanation of the limits of confidentiality, and to normalize the questions, and to stress that we just ask everyone about these things and then just keep asking at future visits. We can also make our environment safer by displaying educational posters about healthy relationships, and making sure that they are multicultural and multilingual to apply to everybody. We can display them in both common areas and in private areas, in waiting rooms, in bathrooms, in exam rooms, in hallways, and other highly visible areas. It's also really important to have resources listed, so resources that patients can write down or take a picture of, or resources like brochures that patients can take with them. And it's really crucial to have those things like hotline numbers, safety cards, resource cards, both in the common areas and crucially in private areas. And ideally, we'll have resources there for not just the potential victims or survivors, but also for perpetrators, because the people involved in these relationships, all of them are potentially our patients. I'm just going to read out a couple of thoughts that are in the chat. Catherine Openchain said, we partner with radiology, so when a teen goes to get an x-ray, we can ask them again there. That's a great idea. And Sarah Cooper said, in pelvic health physical therapy, I usually do some gross motor skills in the hallway or stairs. I have whoever is with the patient stay in the room while we do this, so I can take the patient to a private space to talk. These are excellent ideas. Thank you guys for your contribution.
Yeah, so on the next slide, we have a series of relationship-related questions. And so this is suggested language. Our program here at CHOP and many others across the United States rely heavily on guidance from other entities such as Futures Without Violence. So this is not something that we came up with off the top of our head, but is sort of in collaboration with larger agencies that are having these discussions around IPV and health. So, really just trying to normalize and have sort of a universal intro for when you're asking these questions if you are verbally screening. Something along the lines of, because relationships can be challenging and because stress really affects your health, I ask all my patients about their relationships. And at that point, the patient probably has some sort of response like, okay, but you can also say, do you mind if I ask you a few questions about related to your sexual health or your relationships? And, yeah. And so some things and domains to ask about, not always the bad parts of relationships, right? So what does your relationship look like? What sorts of things do you and your partner do for fun? How would you describe your relationship with your partner? That one's very open-ended, and you might get disclosure from this, or you might get something that is less elaborative, like, oh, good, fine. So it's important to kind of think about how to follow up with those questions, especially if an open-ended question doesn't really elicit much of a response. So yeah, I think something like, all couples disagree or have arguments. What does it look like when you and your partner fight? How do you and your partner handle disagreements or fights? And we say partner a lot because it is sort of a more general and inclusive term, but it's important to remember, as always, to reflect or mirror the patient's language. So if they say boyfriend, girlfriend, friend, whatever, reflecting their language back to them is really important in establishing rapport and having an open and honest conversation about these topics. We can move on to the next slide. To the A of radar, well, I guess the first A of radar, which is asking questions. If anyone has questions, as Amanda mentioned, like, everyone develops their own style. So if anyone has questions, like go-to questions or go-to language, we welcome you to share them in the Q&A feature as well. I think it's always great to learn from each other about different ways to ask. So, I'll give people the opportunity to do that. And while people are, maybe thinking about the questions that they ask or that they might want to ask in a clinical encounter, we can move on to the next slide. for some direct individual questions. More example language here. Do you ever feel forced to do things you don't want to do? Do your fights or arguments ever become physical? And when you phrase it that way, becoming physical, that can mean different things. So you are kind of in one way screening for if someone is being abused, but also if they are being abusive to their partner as well. You know, you're kind of generally asking about, is physical abuse happening? Does your partner put you down or make fun of you? Do they ever make you feel disrespected? Things along those lines. For digital abuse, has your partner posted things to social media about you that you did not want posted? Does your partner want you to get pregnant? How do you feel about that? Someone put something in the Q&A feature. Do you feel safe with the person you're talking with? Yeah, so getting at that safety is really important. Yes, so instead of saying, are you safe? And kind of a lot of the interpretation of what that might mean, do you feel safe? Do you feel okay? Is your partner hurting you? Yeah, absolutely. And if they don't know what that means, clarifying, have they ever physically pushed, hit, or slapped you? Have they ever made you feel really bad about yourself, or like you couldn't do something that you wanted to do? You couldn't spend time with someone that you wanted to spend time with, things of that nature. Thanks. This is really great. I love when people chime in. So yeah, obviously there are a lot of ways to introduce this conversation and to ask questions about relationship safety. Time is a very real factor in these encounters and these conversations. So having a go-to general screening question is great, but being prepared with different ways of phrasing it, phrasing the same question or asking different or follow-up questions is definitely very important to feel prepared. Sarah Jajix, especially if I feel like something might be up and I'm not getting much of an answer, I will sometimes ask kids if their friends or family like their partner, yes, or are supportive of their relationship, right? So how do other people frame it? How do they view it? What's their reaction? So yeah, if their friends and families don't think their partner is treating them right, or they're not a fan of the relationship in some way, that's also really telling and good information to have as well. Would you like that I do something for you today before you leave to make you feel safer? Absolutely. If there's going to be an intervention, what's going to be helpful for that patient? And so there are a lot of ways that we can ask about this, and a lot of different ways that adolescent patients can disclose or answer. And one of the immediate things I think that a lot of clinicians' minds go to, or maybe even social workers' minds go to, is once I ask and I get a response, what do I do? How do I document? What's the intervention here? So that brings us to the D, or documenting. And there are a lot of best practices for documentation for intimate partner violence, for adult population, and teen dating violence is similar. There are a lot of things and a lot of factors to consider. So on the next slide, you'll see kind of an easy 1, 2, 3, right? So first, document that you did the screen, or that you asked, or that you inquired, right? Sometimes this will be, depending on your setting, it will be part of your normal practice that you have to document it. Maybe it's something that's built into a note template to make sure that everyone's asking these questions, regardless of your personal practice. So even if the screen is negative or positive, just document that you completed it. And also documenting if you defer it or you don't complete the screen. Second is documenting that patient's response and using their language, not kind of overlaying an assessment or a judgment on it, just saying, patient disclosed, and then using their exact words. I mean, I'm sure that there are a lot of charting opportunities where it's a simple positive negative, but really kind of contextualize it with the patient's actual response. And keeping things really vague can just be confusing, as documentation, right? And then 3, document any observed injuries. So like the physical symptoms or signs of this abuse that might be happening, including photos and other forms of documentation beyond just words is also what we hear from clinicians as really important. But, documenting your screen is one thing, documenting that you asked, but documenting the assessment and the plan is also important in terms of next steps. So I'm just going to read these 3 points from the clinician's perspective. So dating your assessment of potential for future violence, including threats, right? So if this is a high-risk situation, documenting and voicing also your concerns is definitely appropriate. Describing safety and follow-up plans, including a next scheduled appointment, or maybe it's a follow-up phone call, even if there isn't necessarily a medical reason for follow-up, understanding that there might be some sort of referral or check-in call with the patient. And then thirdly, document resources that you provided or discussed, right? And this is a really good opportunity for safety planning that I'll talk about a little bit later in the presentation, but really it's basically saying I provided the patient this resource, this phone number, this referral, and as long as it's safe for that patient to have that, maybe in their after visit summary or in their chart in some way, including that information so that they know where to find it and they can actually leave the office or the encounter with that information. Okay. On slide 42, the next slide, this is a very new and topical thing that we're all sort of dealing with and considering for the first time. So the 21st Century Cures Act and the confidentiality and privacy concerns that come along with it. So very new as of this spring, April 5th, 2021, it mandates patient access to clinician notes online or open notes. So yeah, on online patient portals, patients now have the access and ability to open an entire note, basically everything that is a part of the documentation of that clinical visit. So the open notes policies must not compromise confidential health information of minors protected by law, at the federal and state level, like reproductive health care. This would include like family planning visits, things of that nature. So those things are still considered sensitive and protected and HIPAA compliant, but understanding that if you are charting in a progress note about a conversation around relationship safety or someone discloses teen dating violence, making sure they understand what you're writing and understanding that they will have viewing or like access to what you're documenting after the visit.
So sorry for the technical glitch. We're not really sure what happened there, but I'm back. So one additional point on the Cures Act is I think that this is such a new area for all of us, is that I think the important thing is that each institution is really kind of working at this at their own pace and based on their own needs. So it's really critical for you all to understand what your institution is requiring moving forward and what that culture is. So be very keyed into what's happening in your institution to understand how these sensitive or open notes are being handled and how these open notes are being accessed by patients and parents alike. Okay, with that, we can move forward to the next component of RADAR. So we're now at our second A, which is assessing readiness and safety. Next slide, please. Thank you. So here we have to be really concerned about the barriers that we all are going to experience in relation to disclosure. So patients are going to be rightly concerned about privacy and confidentiality. And going back to what Amanda had talked about earlier, it's really, really critical to set the stage in the beginning of the visit and not to wait until you're kind of in the thick of some of these questions, because you really want teams to understand when they're saying something to you, what position that puts you in and what is required to be reported and what isn't. And one of the things that's really important for all of you to be aware of is that this also is something that's going to vary by state. Each state is going to have its own separate laws around age of consent, around statutory sexual assault rules, when you need to report, when you don't. So it's really important for you to look up your state laws around this and be really sure before you're going into any of these visits to really understand when you're required to report based on what you're told. Teens may also be worried about parents or caregivers finding out that they're in a relationship that may be unhealthy. So it's important for you to understand that as you're discussing this with teens. And I think the key thing here is to understand that our goal is not to have people divulge something to us. Our goal is really around safety of the patient. So that the divulging of information may come at different times for different patients. And it's important for us to recognize that and not push the issue. We have to think about, in terms of what Rachel was saying earlier, that teen relationships are a little bit different than adult relationships in that a lot of times friends, they all kind of go in the same circles. So your partner may have a circle of friends that you've become really close with. So when a relationship ends, there may be this fear of additional loss, not just loss of the partnership, but also loss of a circle of friends. It can be really isolating when that can happen. So it's important to recognize that this may also be reasons for why teens are not telling us what's happening in their relationships. And we need to just be patient, be supportive, again, not being judgmental as we're having some of these discussions. And then finally, there's also fear of sometimes being forced into making decisions that they may or may not be comfortable with. And this can, again, go back to safety issues. They may know what the level of safety is in their relationship right now. We may not have that information. So it's really critical for us to be aware of that, not push them in a direction, but really to go at their pace and give them autonomy here in the decision-making, in the planning, in how we're going to address the issue. Next slide, please. Again, continuing with readiness, one thing that's really important is for there to be an established trusting relationship with a provider. That may happen with any member of the team. And as Amanda had alluded to earlier, it's really important for us to use a team approach so that not that everybody's going to be asking the same questions across the board, but when somebody hears something or learns of something from a patient, that they're ready to respond to it, to be able to address it in a supportive, caring way, and to respond appropriately by referring either to the provider of that visit or to an outside referral. It may take several visits for this to happen. It may not happen overnight. And I think also to something Amanda alluded to earlier, it may happen at a time when you're not necessarily ready for it or you don't think it's going to happen. So being prepared at all times is really key. One of the things that may be helpful is providing handouts either in the office, in the visit, having them in the exam room so that while the provider's not in there, if the teen wants to grab something, they're able to grab it. But it's really around setting a culture that displays to the patient that this is a place where it's safe to talk about some of these issues so that when they are ready, they can vocalize that to us. Again, be patient with folks and don't judge. Our primary goal is always going to be safety and not pushing someone to make a decision they're not really comfortable with. Next slide. So some of you may be familiar with the cycle of change theory, and this is by Prochaska and DiClemente. And you can see here the spiral that happens, and you typically will start with any behavior, but in relation to teen dating violence, we can start in the pre-contemplation phase. And in the pre-contemplation phase, there's really not really the intent at that point of changing behavior. The goal here is to think about not detecting a problem, but really raising the issue of awareness for patients and getting them to understand what a healthy relationship should look like. And that may get them, thinking along the process that maybe they aren't in a healthy relationship. They'll move along to the contemplation phase where you can begin to see that there's an awareness of a problem, but there's not really a commitment to act. They begin to weigh the pros and the cons of what it might mean to either stay in that relationship or leave that relationship. And then from contemplation, they move into that preparatory phase, where they're preparing to really decide how they can take action and how they can change the behavior or potentially get out of the relationship, do some things within the relationship to make them safer, or work with the partner to try to build communication and try to understand how change can be made. Next, we move to the action stage, where we're now moving into that. They understand that there's an issue in the relationship, and they're at a point where they're ready to take action. And that may mean leaving the relationship. It may mean staying in the relationship, but making some changes within that relationship to make things safer. We move from there into the maintenance stage, and the maintenance stage is when the goal is really to try to build sustainable behavior change. So whatever change was initiated in that action phase, we're now trying to maintain it. And if you think about this in terms of kind of getting behaviors that will replace that old behavior, so this can be things like potentially building new friendships, hanging out with friends or family more often, and maybe getting a new hobby, joining a sports team, anything to kind of fill that void of the loss that we talked about on previous slides. And then next, there is a potential for relapse. And I think the key here is to not consider the relapse necessarily a failure, but something that's a natural course of action in terms of behavior change. We've all been there. We've all tried to change our behavior for something or another, and we know it's hard. And just because you kind of relapsed and went back into the cycle doesn't mean it was necessarily a failure. So I think something that's key here is helping the teens realize that this may happen and it's okay, and to support them through that. And then the goal is to get them back onto the cycle again, whether they join in the pre-contemplation phase or they join back in the action phase. They can jump in at any phase of this cycle, but the goal is to kind of get them moving through and get them to that maintenance stage where there's a healthy behavior in the long run. Something to keep in mind is that these phases can be different lengths of time for each of them. Some of them are shorter, some may take years in this process. So I think the key for us is just to be patient as a provider and know that this is a natural cycle that they're going to work through. So here on this slide, we can see this is from the Bernie group, and I thought this was a great example of how when people are moving through these behavior stages, the cycle of change, you can see that there are different emotions involved. And as Rachel had alluded to earlier, of the cycle of violence, this kind of makes sense when you look at this, and you see that in the beginning, there's that shock and denial and that avoidance phase that we're talking about. That can move into the next phase, which is this mild anger, where we have these emotions that we're upset, that we recognize we're in this unhealthy relationship and we're upset by it. There's some anxiety, there might be some embarrassment in terms of social capital that might happen here. And then we move into that detachment phase where we're just kind of overwhelmed. Like, we've recognized that, yes, we have this issue, and now we're trying to figure out, what do we do? So this is the preparation phase. And then when we move into that action phase, you can see some of the associated emotions are in that understanding. Like, you may now be thinking about reaching out to others, wanting to tell your story, maybe to perhaps protect other people who are in this situation. And you're going to struggle at this point to try to find meaning for how this all happened, why it happened, building up your self-esteem and confidence again. And then you move into that acceptance phase. Okay, so you're now embracing those options that you have, developing that plan. You're now putting in place all those new actions that you'll be doing, and you have a true desire to move forward. And then that transformation phase here at the end, you can see there's empowerment, there's security, that self-esteem is kind of building, and you've developed some sort of meaning out of the process. So I thought that was a nice graphic here to represent those different emotions throughout that stage of change. Next slide, please. So in this entire process, again, one of the key things is safety. So what we need to do is constantly be assessing for safety. And there are two different ways that I tend to think about this. I think of immediate safety concerns, and then I think of the longer term safety concerns. And as Amanda pointed out very eloquently early on, we only have so much time in all of our visits, right? So we have to focus on the critical pieces. And I think the critical pieces are that immediate safety assessment. So is it safe to leave today? Is the partner out in the waiting room? Will they be aware that you discussed some of the things you discussed? Is there going to be an escalation of violence when this patient needs your care today? Does the patient live at home with the partner? That may offer some additional safety concerns than if they were going home to a parent's home, for example. What can you do about getting them to and from school? Are they safe doing that? Are there things that you need to consider in your safety plan right now for tomorrow that you need to be thinking through with your patient? As always with adolescent care, I think we always try to suggest involvement of a parent, particularly around health issues, whether it be a medical issue, an emotional issue, whatever that may be. We suggest strongly to the teen that it would be helpful to have an adult, an important adult, a supportive adult, help us work through this. So suggesting that to the patient, by no means would you just go ahead and do that without discussion with them and without their consent. Of course, that's excluding all of those issues where we are required by law to break confidentiality, which is why it's so important to divulge those at the beginning of the visit. We also need to know if the patient's planning on hurting themselves or someone else, or do they have access to a weapon? So some of these things are those immediate safety concerns we need to address right away in that visit. Next slide, please. So back to the Q&A, which I think you've all been great at participating in. What are some ideas that you all might have for addressing safety, those immediate safety issues, as you have a patient sitting in front of you? And then finally, as you're populating that in the Q&A, we'll move to our final R in radar, just so we have some time at the end for some question and answer. So after we get a disclosure, what do you do? Of course, this is the part where you get really nervous and you want to stay. I think the key thing is to take a deep breath, try to stay calm. Like Amanda said, keep your poker face, okay? Thank them for placing their trust in you and let them know that you're going to be there to support them. Let them talk through it. It's really important once they open up to let them open and just get out what they need to get out. You want to hear how they're feeling, and you want them to help you in developing the plan. You want this to be a team effort. You don't want this to be something that you're dictating to them. Again, you need to know where they are in those stages of change and what their comfort level is around their safety. You want to be supportive and make sure you're checking your own judgments at the door so that you're not closing off any discussion. You don't want to push them into making decisions to move out of the relationship because that may not be the safest thing for them right now. And as we saw in previous slides, like stage of change is really important here. So validate their experiences, let them know this is common. It doesn't make it okay, but you're there for them when they're ready to talk about it more, or if they are talking about it now, you're ready to help them come up with a plan. Next slide. And then what to do. I'm just going to quickly summarize this one here because we focused a lot on safety, which is the thing that I will repeat again and again and again. Staying calm, focusing on that harm reduction and safety. A couple of the key things that I want to present here, just tangible items that I think are really helpful for safety planning with the patient, and Teresa will talk a little bit more about some of this, is to maybe set code words with folks. And code words are things where it's a specific word that isn't used very often that you can have your patient discuss with key people in their lives that they trust and they know will be safe. So a code word might be something like, I haven't had a banana split in a really long time. So it's something that the partner wouldn't necessarily know something was up, but your close friend who you've shared this code word with will know that that's a key for them to know that you're in an unsafe situation right then and there. And that's that you kind of need to kick into action and help get you to safety. There might also be things that you can do about staying in public places, hanging out with other folks so that it puts you in a safer situation. And then I think the other thing here is to refer outside and do a warm handoff when you're at that point and you know that it's important. So that trauma-focused treatment can be really important in these situations, and just know your limits and know when it's time for you to hand off, and do it warmly so that the patient feels comforted with the person that you're handing off to. Next slide. Great, and I'm going to hand it over back to Teresa.
Awesome, thanks, Christy. Yeah, I think all those are really important action steps for how to respond to disclosures. And keep the conversation around safety going. I want to just highlight this slide as well as the next slide will be basically a list of questions or things that are just to elicit some brainstorming around immediate and longer term safety concerns for teens who are impacted by teen dating violence. So it is from one of the published articles that is included in our resource slide. So I'm not going to read through all of these, but it's basically a series of questions and safety considerations that can help in the process of safety planning with patients. And you don't need to be an expert in order to make an impact here. Anyone can make a safety plan, and I think looping in another support person or a trusted adult in that teen's life is really, really key to making everyone feel better about the situation, right? Really particularly want to highlight safety around communication and phones or cell phones, getting really creative about how you can get back in touch with this patient can be the #1 kind of line of defense for this. And so on the next slide, when we think about, less immediate concerns like, where are you going today? Are you going somewhere safe? How do you get help if you need it? Thinking about some of the more longer lasting impacts and longer term safety considerations. So considering all realms of safety, right? Physical, emotional, digital, and then kind of health related or reproductive safety. These are some of the things that we pulled out as highlights, right? So there are some longer term consequences of someone's personal information being shared or compromised. Teens might feel avoidant of or anxiety around technology as a result of digital abuse or other types of abuse. They might feel hypervigilant or have really like a practice of negative or escalated communication patterns. So if someone is fighting with a partner all the time via text or on the phone, how are you able to support them in communicating in other more appropriate ways with other people in their lives? Emotionally, we do know that even after someone leaves an abusive relationship, they are still at risk for future victimization and future relationships in adolescence and adulthood. Increased substance use, depression or anxiety symptoms, and suicidal ideation or acts, unfortunately. So in terms of longer term, it might not be today, tomorrow, next week, but we do know that survivors are really good at keeping themselves safe, but there are a lot of mental health symptoms that might come up as a result of the trauma of this abuse. So yeah, unfortunately, teens who have experienced this are 2 to 3 times more likely to complete suicide. So suicide assessment is definitely something that can happen in conjunction with teen dating violence screening and response. And then reproductive, in terms of kind of longer term contraception options, long-acting reversible contraception such as IUDs or Nexplanon. How do we use emergency contraceptives? Access to abortion services. Obviously, if someone's a minor, there are several steps that are involved in getting access to those services. And then STI disclosure. So a lot of components around basically how do you disclose to past and future partners about your status around various STIs. There can be a lot of anxiety and mental distress around that, especially if someone was unknowingly infected or unfortunately intentionally infected by a partner. Those are some examples of just situations that we've heard of before and had to have supported adolescent patients around. And I think that's where we were gonna transition the safety planning conversation into more of a Q&A moment. So I'll let you talk about that, Rachel.
Sure, and we want to be respectful of folks' times. Thank you for bearing with our technical issues. We will be sharing these slides with everyone at the end of the session. I know that's always a question. I think if we can flip through to the champion slide, we'll leave that one up for folks, which has just a couple of things to think about to take with you into your practice. And I know we're running close on time. I do want to acknowledge a couple of the questions that came in today. There was one question that came from Jackie about when you're making decisions about disclosure and reporting, how do you take into account a diagnosis of an intellectual disability? And Amanda, I wonder if you might have a few quick thoughts to share on that one.
Yes, very quickly. I can respond to that, and I can respond to the other question about if open notes are going to be sharing with families in addition to. Yeah, so the question about intellectual disability is a great one, and I'll just be very brief in saying that I think this is an area that varies widely state to state. And yes, intellectual disability may make a difference in the patient's ability to consent, and thus legally, this is handled in a nuanced way in different places. So I would say it's another reason to consult your resources. Social work, here at CHUP, we have an Office of the General Counsel with attorneys who are experts in the law who can support us as clinicians and the social workers if there's lack of clarity in a situation like that. And so I think my quick answer to that would be absolutely take it into account and consult your local resources to see how your state law deals with that issue. And the other question, which was, does the right to view the chart also go to the parent guardian viewing the chart, including confidential information that the child or teen is given and our response and the resources we gave? I think that as my colleagues were sharing, this is a very new law, and the reality is, yes, it may, and ideally we will create systems in all of our individual technological worlds in our healthcare organizations that will protect the information that is legally protected in that state for that patient. So, but this is just all coming into being, and so each organization is dealing with it in a slightly different way. So I think, yes, it could get shared with parents. It shouldn't include, the sharing shouldn't include protected information, but there is a risk that it may as we're just grappling with these. And so I think it's important, if you're in a position dealing with these patients, to ask your local information services authorities and your health IT professionals how your electronic medical record or your medical record is being protected, and whether there's a mechanism to protect in particular specific sensitive notes.
Great, thank you. And what we'll do is, I know there are a couple more questions that have popped in. When we share the slides, we'll also share responses to some of these questions, because I want to be mindful of folks who are waiting anxiously for the evaluation so they can get their CEU credits today. So we'll go ahead and wrap up for today. As a reminder, if you are a social worker or a nurse and you want to claim your continuing education credits for joining us today, you are required to complete a survey. There is a link here. We will also send it out afterwards, and we'll try to put it in the Q&A for folks to click on. As I just mentioned, the resources that we shared today will also be provided in an email out to participants later today or tomorrow. We want to thank everyone for your incredible participation, for the solutions you've offered, the questions you use with your own patients. And we really do appreciate all of the work you do to help protect and enrich the lives of the adolescents in our communities. We hope this webinar was useful and actionable for you, and that you'll be able to utilize the recording as well as the resources we'll share for your own practice as well as those you work with. I want to extend my biggest thanks to our presenters and our content contributors, Amanda, Chrissy, Teresa, and Catherine, as well as our Center for Violence Prevention Outreach team, Lindsay Mitros and Madeline Smith. And thank everyone for joining us, for spending your lunch hour and a half with us, and hope you have a wonderful afternoon. That's all for today.